How are you? My name is Paulo Pino. I'm VP and Medical Director of Innovation at Variability Clinical Solutions. We're formerly Diameter Health, and today I'm going to focus on the use of natural language processing to address medication instructions. And so the title of the presentation is Medication Instructions, Variability Prime for Disruption Through Natural Language Processing. So going to address a couple of key topics into why this issue is timely and important. We know that care is increasingly becoming complex, and I think that there's no better way to look at the complexity of medical care than to look at the ever-increasing age of the population. So you could see that by the age of 2035, more people are going to be over age 65 than under age 18. And this is a significant issue from a population standpoint. We also know that with advancing age, there's certainly increasing medical complexity. In addition to the increasing medical complexity, we also know that medical science has evolved, so medications have become much more complex. They have more nuanced instructions. We know that an era of personalized medicine has certainly evolved, and that era of personalized medicine leads to differential medication dosing regimen for individual patients. And so these are going to contribute to increasing challenges in the population in terms of medications. And so just to give you a sense of some other challenges that our healthcare system faces, it's a perpetual system of addressing chronic illness. It tends to be reactive care. Many patients have multiple different morbidities, and the causes of morbidity and mortality are largely non-communicable disease, so chronic illness like diabetes, hypertension, et cetera. We know that the most complex patients, and certainly among these are the elderly patients, have the most complex care delivery models. So in an elderly population, less than 50% of elderly patients are up to date with their routine screenings. They take significant amount of medications, and take up to 19 different medication doses daily. They see multiple different care providers. So average person sees yearly 7 different doctors across 4 different practices. If you end up having a surgical complication, that can lead to 27 different care providers. We know that largely 1 in 5 patients are readmitted at 30 days. These patients that are admitted follow up less than half the times after hospital discharge, because of some of the challenges in accessing care, but also just not understanding the complexities of their own care and the rationale for a need to follow up. And we know that some of these issues lead to are complicated by medication errors. We know that medication errors are prevalent, and I'm going to show you some statistics to that. We feel that EHRs should be the solution, but all too often they're actually contributing to the problem as well. So we know that medication errors in general contribute to between 7,000 and 9,000 deaths annually. There's hundreds of thousands that experience a medication error that's ultimately not reported, that may have morbidity impacts or may not even have morbidity impacts, but just is underreported. We know that from a cost standpoint, it contributes to about $40 billion of cost associated with these errors. We know that there's a fair amount of psychological pain and suffering and patient satisfaction issues that are not addressed and are not captured by these costs and these deaths annually. We know that medication errors are common in transitions of care. So we spoke previously about that elderly patient going from an inpatient setting to an outpatient setting. So we know that in these transitions of care, 67% of patients faced unintended medication errors. 40% were largely due to miscommunications and handoffs, and 80% of these were due to transitional communications due to differences in style, distractions, and lack of standardization in how data was exchanged. We know that the accuracy of medication data in electronic health record population and a geriatric population faces some of the similar fates as we see in general population. We know that in a geriatric center, 91% of medications were represented correctly in terms of their compounds. We know that 1.3 medications per patient were ultimately missing or uncoded, with 0.37 being missing altogether. We know that patient reporting errors were responsible for about 36% of these. Failure of capture of changes to medications by outside clinicians were responsible for about 25.9% of these. Transcription errors were responsible for about 8%. We know that only about 90% were correct in terms of compound identity at the source. And additional errors of omission were due to things like free text being uninterpretable to medical decision support systems in electronic health record systems. EHR-related errors had suffered similar fates in intensive care units. This was actually a study done by Carrion et al. There's about 1,600 total preventable adverse drug reactions, of which 34% were related to EHRs, delivering issues like errors derived from overdose, omissions, wrong medication, duplication, and then wrong dates and wrong documentation altogether. This study actually showed that EHR-related error had significantly more risk of serious harm to a patient and equivalent risk of life-threatening harm to non-EHR-related errors. And in terms of EHR-related errors and their involvement in malpractice suits, this was actually a study done by Graeber et al. That actually looked at 248 malpractice claims involving EHRs. 31% of them involved medication errors, 63% involved user errors, and 80% or more led to severe harm for these patients with significant loss of function or loss of life. So in order to understand med-sigs, which is something that we've abbreviated in the title, I wanted to just quickly talk about the anatomy and physiology of a med-sig. We'll talk about what's in a SIG, how does it look, and what vocabulary does it ultimately use. And so this is actually a prescription that I've written myself for Jane Doe, who really does not live at 123 Main Street in Spangle, Ohio, but she's a synthetic patient. And you can see that the prescription on the left has a bunch of different parts. So we'll start off with the top. My name and my blurred out address and phone number and fax number are the prescriber information. My drug enforcement agency number or DA number allows me to transact controlled substances, and that's in the box below that. You can see that there's patient information like name and address, as well as date of birth in this. You can see that there's a date of a prescription. And now we move into the body of the prescription itself, how the medication is actually written. So you see the RX that's over to the left on that prescription. That's actually the superscript, or the abbreviation for recipe, RX recipe. The next, you actually see the inscription, and that's the medication prescribed. In this case, it's amlodipine 5 milligrams. Below that, you actually see the subscription, and the subscription is the instructions for the pharmacy, and that's dispense 30. And then you see the signatura, which is the directions for the patient that I've highlighted. This is the med-sig that we're talking about. And then you see the provider signature, which is actually at the bottom, and that's my signature. So the signature contains a couple of key pieces of information. It's abbreviated SIGNA or SIG. These signaturas contain the method of administration or application, the dose if the preparation is for internal use, the time of administration, the diluent used, so things like water, or the means of application, like apply it with a brush. They contain the parts of the body where the preparation and application should be happening, and they contain any special instructions or conditions of use for this particular medication. And so you'll notice that on this particular slide, I documented as QD. So QD is actually a dangerous abbreviation. And here are some of the laundry list of abbreviations that actually are included in a prescription. And then over to the right, you actually see some of the dangerous abbreviations, like using the letter U for unit, or using QDay or lowercase qday for daily, not to be confused with QO day for every other day. Things like international unit can actually be mistaken for intravenous. And so being careful in terms of abbreviations are important, but these abbreviations are, found very often in prescriptions and lead to some of the medication errors. And that's regardless of whether it was a handwritten prescription like you saw there, or an electronically prescribed prescription. There is the flexibility for the provider to document at the point of care in ways that are free text, and they can include things like QD and QOD, IU, and IV. So let's talk about why pursue NLP. So we know that clinical notes contain key pieces of information, and this is a patient that's named William Weston. And William Weston presented to the primary care office for a follow-up of hospitalization where he was admitted for hyperglycemia, dehydration. He was admitted with a condition called hyperosmolar coma due to poorly controlled diabetes and an accelerated increase in blood sugar. And so you could see that the prescription that's written there is a Lantus pen, subcutaneously inject 5 international units by subcutaneous injection once daily. And this dosing was ultimately discontinued. This data actually came from parsing of data that was performed by an HIE solution, a health information exchange solution, and abstracted by a skilled nursing facility where the patient was at, that was ultimately perpetuated in part of his record. And so if you look at the actual dose correction at the bottom, what it should have read was continue Lantus pen subcutaneously 30 units daily, increased by 5 units daily until fasting blood sugar is less than 150. And so this was corrected in this one clinical note. But it's all of this noise that you see here and all of these areas that are sort of obscured that really contain rich information in the document that are not structured like a med-sig, that actually provides great insights into documentation in terms of opportunity to really capture what was intended at the point of care. And so what NLP ultimately does is it takes these unstructured medical records that are comprised of things like clinical notes, chief complaints, medication instructions, free text fields, reports, and then outside of the record, things like social posts, wearables, ancestry documentation, 23andMe documentation, police records, and really creates one structured medical record that really is entirely comprehensive and really can follow the entire clinical journey of this particular patient throughout their history. And so it pulls out things that are structured like allergies, lab tests, medications, procedures, and problems that already exist in structured format. And this NLP structured data actually enhances that to just provide more robust insights into what's gone on for a patient. And so if you look at the med-sig, and we'll highlight William Weston's chart again, you can see that the Levemir Flex Touch Pen, 100 units per ml, is actually the structured part of the record, and the instructions are off to the right, which actually include the unstructured part of the medical record. And so it's really this light blue or teal stuff that we're looking to actually look at to parse using natural language processing to be able to derive greater insights. So let's talk about the combined power of Fusion, which is the offering of my organization named Variability, and John Snow Labs Spark NLP for improved med-sig parsing. So our solution, and we talked about the structured and the unstructured elements of this clinical chart. So our solution really focuses on the structured elements of that chart. And what we do is we find that clinical data is actually, in its raw form, is actually largely non-conformant to clinical standards. There's supposed to be certain schema and schematron about how clinical documents are exchanged. And there's also supposed to be specific vocabularies in terms of how that exchange is happening as well. What we're finding is that in addition, instead of having this conformity, there's a lot of variability that happens based on different electronic health record platforms, from provider to provider, from different implementations of the same electronic health record platform, and even from patient to patient. We find that certain demographic aspects may actually influence the way documentation happens in a particular patient's chart. And so what our solution does is seeks to try to establish normalization and standardization of this data to create one longitudinal data asset that's truly semantically interoperable. And regardless of what format and regardless of what source that data came from, it really tells that longitudinal story when amalgamated with other data sets about that particular patient. And so the way we do this is through a 5-step process that we call Fusion. We normalize the data to industry standards. So for things like problems, there's the International Classification of Disease, or ICD-10. For medications, it's something like RX norm. For labs, it's LOINC. So there's different standard terminologies that exist. We'll actually take that to those different standard terminologies. We enrich the data with key pieces of metadata and classifications. So for example, we'll take information about a prescription and actually classify that drug a higher level for that drug classification. So if someone, for example, is on morphine, we've appended to that they're on an opioid. We've also appended to that they're on a scheduled medication. And so that's an example of enrichment. Reorganization, we find that there are certain aspects of data that are in the wrong clinical sections of charts. So you may see, for example, vaccinations that come in the medication domain. So we'll actually move that over from the medication domain into the vaccination domain or the immunization domain. We'll deduplicate the data so that documents that have repetition within themselves, documents that have repetition across different documents, even certain conditions which may be chronic and shouldn't be replicated throughout the entire care journey, we've deduplicated those. And lastly, we summarize, and we take and we create one longitudinal data asset that really tells that full patient story for this particular patient. So let's talk about what we do in terms of med-sig parsing. So here's an example of a prescription, and this is a prescription for lisinopril 5 milligram oral tablet. And the instructions are take 5 milligrams BID with meals. BID means twice a day for those that don't know medical abbreviations. And so what we first do is we'll convert the unstructured prescription to structure. We've basically taken that to take 5 milligrams lisinopril twice per day with meals. And then lastly, we take that structured data and we encode it. And so you could see that, we encode it into a bunch of different parts. The first thing is we take out that medication, lisinopril, and we normalize it to one of those medical terminologies that we've spoken about before. In this case, really addressing the structured element of this prescription, right? Now, the signatura part, which you can see at the bottom, is where we'll take that and we'll divide it up into individual component parts. Like, for example, we've taken tablet, we've taken the unit of the dose, which is 5 in milligrams. How this is to be taken, we've divided up into oral, how frequently it's done, if there's any special instructions, like in this case at mealtime, and then determine whether or not the medication is active or not. And so this is our general rubric for med-sig parsing. In terms of Spark NLP for healthcare, they're actually doing similar things, and this is actually the John Snow Lab Spark NLP for healthcare parsing of this same instruction. So you could see that there's the word prescribe, which actually is providing that sort of initial instruction. You can see that there's an entity recognition and data normalization. The dose in milligrams is actually included here. You can see that the name of the medication is azithromycin, and it actually gets normalized to RX norm. You can see that there's sentiment of a spell check diagnosis. In this case, there's pneumonia, which is actually misspelled and corrected. You can see there's negation with the word without. And lastly, you can see the addition of SNOMED CT for something like shortness of breath, or SOB. And you can see that that's been, that goes to dyspnea there. And so what we've actually done here is a study looking at how does Fusion behave alone? How does Fusion behave when added to Spark NLP? And that's what the rest of this presentation is going to be, is really the breakout of where the individual strengths and weaknesses were, and where the combined strengths of both products actually existed. And so you can see that what happens here, and the Availity logo is in those things that are actually taken care of by the Availity solution. The John Snow Labs logo is actually in those things that are handled by Spark NLP. And so you could see we actually will strip the HTML, strip the dates, we'll aggregate, double numbers when there's double numbers in the prescription, in the SIG. We'll send that through Spark NLP sentence detector, identify the parts of speech, which you saw on the previous slide, perform named entity recognition, and then we'll actually take that over into our detector to find out things like direction, any modifiers, in this case, PRN or as needed. In this known terms, in this case, things like by mouth Q day or daily. In terms of range detection, like things like 1 to 2, number detector, things like a half, and then a unit detector, which is for milligram. We then process that through the named entity recognition converter. And then on the outside, we parse the route, the form, the dosage, the strength of the parser, the frequency of the parser, and the duration of the parser, and really create, that one, full sig writer that builds that rebuild med sig for this particular prescription. And so in order to really show the value, I wanted to take you through some definitions. So you can see that I've divided up prescriptions into routine, non-routine, and those medications that were excluded. Looked at about 180 different prescriptions. In this case, routine contained things like simple, just take 1 by mouth daily. Conditional, things like take 2 by mouth once daily as needed for pain. Variable frequency, so you could see 4 to 6 hours in that particular frequency. Variable dose, in this case, 1 to 2 tablets, which is the dose variability. And then I looked at non-routine prescriptions, things that were complex. Here's an example of azithromycin. So this is 250 milligrams. It's take 2 tablets the first day, and then 250 milligrams or 1 tablet days 2 through 5. Things that have variable dose and are conditional. In this case, you could see the 1 to 2 tablets and the as needed for breakthrough pain. Those that contain detailed instructions, this is not only simply apply 50 milligrams to skin, but it also specifically says in the morning to the shoulder, to the upper arms, or to the abdomen. So more detailed instructions. Detailed instructions and conditional include, as needed for wheezing, and then explain that it should be inhaled. And then there's those that are the most complex that contain variable dose, detailed instructions, and conditional. Here's 1 to 2 prior to sexual activity, maximum of 5 per day. And so these are the examples of the routine and the non-routine prescriptions that we addressed. In terms of the excluded, we excluded those that were non-medication, things like take blood sugars 2 times a day, or a poor inbound prescription, which is follow the schedule on the package inserts, for example, which we didn't obviously take through to kind of test the validity of our combined solution here. And so in terms of accuracy, we looked at, does it capture the medication's prescription correctly, the SIG correctly? This is validating both the clinical intent of the prescriber. And so in this case, there's, it's really done 100% accurately. Is there med sig that's partially captured at no risk to patient safety? So in this case, there are errors, but they really don't pose significant risk. There may be key pieces of the sentence that we're missing. And lastly, does it capture the med sig erroneously? And does this present a risk to patient safety? And so let's talk about, the type of SIG. And so these are routines. And so you could see by and large, when it was simple things like take 1 prescription daily, if there was multiple unit doses, like 2 tablets, if it was variable dose or variable, frequencies, even, to some extent, conditional things like, as needed for pain. Both the Fusion rebuilt and the Fusion with the John Snow Lab Spark NLPs actually did really, really well on these prescriptions. And you can see the green color actually represents that. This is actually a slide looking at situations where Fusion succeeded, but the John Snow Lab Spark NLP didn't succeed. And in this situation, you can actually see, or didn't 100% succeed. So things like the term AM before breakfast. So you could see take 1 tablet by mouth before breakfast is the Fusion rebuilt. But when we added Fusion and John Snow Lab Spark NLP, it was take 1 tablet by mouth morning 1. And you can see one from a patient safety at the bottom is take 1 tablet by mouth minute 30, where it's actually take 1 tablet by mouth daily 30 minutes before breakfast. You can see that things like injection every week were sometimes left off, but by and large, fairly similar across the board. These were the situations where there wasn't necessarily enhancement by the addition of NLP. Partial SIG captured tended to happen with detailed instructions. So in this situation, you can actually see, apply one dose transdermally. We're missing out on things like to most painful areas, and it really was missed by both solutions. In this situation, you can see that the original SIG has all of these, shake gently before first use, prime pump, after use, clean tip and replace cap. Really not an issue from a patient safety standpoint, but they were omitted in the Fusion rebuilt and the Fusion and John Snow Lab Spark NLP solution. And again, you see some other special instructions where, in the case of migraines, may repeat after 2 hours if needed. In the case of an inhaler, they should rinse their mouth after each use. Those particular instructions were actually omitted, but really don't pose a significant issue to patient safety. And so these got yellow rating. And so really where the value of the combined solution was in the complex SIG. And so you can look at the example of this insulin, which is 100 units per ml, max 100 units per day, 30 units increased by 1 unit daily until fasting blood sugar less than 110. Fusion rebuilt was inject one international unit by subcutaneous injection once daily. By the time we got to the combination, you could see that that's max 100 international units by subcutaneous injection per day and take 30 international units per day, increasing by 1 unit per day until fasting blood sugar is less than 110. You can see with Zithromax, again, that take 2 tablets the first day, 1 tablet each additional day for a total of 5 days. Fusion parsed that as take 2 to 5 tablets by mouth once daily, whereas the combined solution was take 2 tablets by mouth day 1 and then 1 tablet days 2 through 5. You can see special instructions by subcutaneous injection every 14 days. You can see their terminology from the Fusion standpoint doesn't necessarily have the 10-day interval because it's an uncommon interval, but the combined Fusion and John Snow Lab NLP solution does. You can see that when there's odd dosing frequency, things like, twice a day for 2 weeks, that tends to alter things. So by and large, the addition of the John Snow Lab solution to Fusion enhanced the accuracy of parsing of these medication instructions that were more complex. And so if you look at out of the 180 solutions, we did fairly comparable, on the simple and the routine instructions. As you get into the more complex, our product alone, when you don't use NLP, really does, poorly, for the complex prescriptions, and only 2% of the time do we get correct med sig. Whereas if you look at the out-of-the-box solution from John Snow Labs, you can see that correct med sig goes up to 47%, which is pretty impressive for this additional information. And so all in all, handling of non-routine med sigs, those that are complex, detailed, and combinations, the Fusion rebuilt, had significant error rates that you could see over in the column under the last columns under Fusion rebuilt. You can see 100% for complex, 53% for detailed, 75% for detailed instructions that were conditional, and 61% overall. When adding Fusion and John Snow Lab together, you can see that those error rates for complex SIGs and detailed and combination instructions actually go down considerably to 33%, 10%, 0%, and 12% overall for these complex prescriptions. And so just in terms of going back to this slide, you can see that the combined solution offered, effectively an 88%, medication safety opportunity here with only 12% of a challenge, whereas the combined solution, whereas the singular solution here was really only 39%, from the patient safety, and offered some concerns, a significant amount of times more. And so just some conclusions. Medication errors are pervasive given the increasing medical complexity of an aging population, the personalization of medication treatments and regimen, the complex transition of care that exists, the documentation variability posed by EHRs, providers, and patient factors, there's a fair amount of negative impact on morbidity, mortality, and cost of care. For those errors that are related to transcription and documentation variability, the combination of data upcycling and NLP can drive impacts. It can really impact those that are complex SIGs. The most complex SIGs were those that had conditional, variable dose and frequency, and they continue to present problems. And ultimately, what we've shown here is that individual solutions are great, but it really takes a healthcare ecosystem to really improve patient outcomes, patient satisfaction, and ultimately improve costs. And so I'd like to talk about some people that helped me with this. So first and foremost, our chief architect at Variability Clinical Solutions, Sam Schiffman, who's been my partner in crime on really amalgamating some of the technical with some of the clinical. And he's over on the right there. And he actually took this on a Zoom call that we had with some students that are working with us at WPI. Their clinical instructor, their instructor, Ben Gunn, Kuel Mishra, who's a master's student, and Madeline Chudy, who's a master's student as well at WPI, who are really looking at sort of combination solutions to help improve challenges like MedSig parsing. Thank you very much.